Have you ever experienced brain fog? Or maybe having some issues with your bladder? What about waking up one day and suddenly you can't see properly and then it's back like nothing happened? Or you've got pins and needles that is lasting more than 24 hours. All of those symptoms could mean something. Stay tuned. Hey everybody, welcome to another episode of the Relebogile Mabotja podcast. Subscribe and hit the notification bell and let us know who or what you would like to see us talk about on this podcast. Now, today's conversation is one that is so critical and important that even in the field of medicine, it can be described as the invisible journey. We're talking about multiple sclerosis, and you might be thinking, what is that? I haven't been watching Grey's Anatomy in a while, because those are some of the places where we get to find out about rare conditions or conditions that people suffer with, where they sometimes get misdiagnosed. Do not worry. We have a neurologist that is with us to take us through MS, as some people refer to it as, and to really talk to us about the signs, the symptoms, and why it's important that you all are aware about MS. And of course, thank you so much to Novartis for bringing this very important conversation to the Relebogile Mabotja podcast and to all of you. I'd now like to welcome our guest, Dr. Taniel Townsend, who is a specialist neurologist that has dealt with cases such as these. Welcome to the podcast. Thank you for joining us.
Thank you for having me.
I have to just say, I have the utmost respect for neurologists, because you got through 7 years of studying and said, I need to study more.
Yes.
How much more did you have to get through to get to the neurology part?
So we obviously do our internship in community service, but the studying part of it for neurology, you can take two routes. You can either become a physician and then a neurologist.
Yes.
I just went straight into neurology, so that was an extra 4 years.
And for anybody who's not familiar with what a neurologist does, what is your area of focus on the human body?
So that is a great question, because I think a couple of people, or many people, have heard what the word neurologist as a speciality, but they're not quite sure what we do. And even some of my friends still don't really know what I do.
As long as your GP knows what you do.
Yeah, it does, yes. So my kids don't. I don't even think my kids know. But anyway, so a neurologist deals with disorders of the nervous system. And the nervous system encompasses the brain, the spinal cord, the nerves, the peripheral nerves, and some of the muscles. And when something goes wrong in this incredibly complex system, it's the neurologist's job to piece together what a patient is telling them. So listen to their story, do a physical examination, and then perhaps do some extra investigations like scans and blood tests, and then piece together where we think the problem might be, what's caused it, and then most importantly, try and come up with a plan to help the patient.
How much of your work is wrapped around knowing and understanding the brain?
Most of it,
yeah.
Most of it. And that's one of the beautiful things, and that's one of the things that enticed me into neurology, is I think the brain is, I think you either love it or not, or you don't as a doctor. I love it. I think it's this beautiful puzzle that makes sense. It's quite scientific. Structurally, you can locate things when patients are complaining of certain symptoms, and it's pattern recognition. So I love the brain. Most of it is the brain, and the brain drives everything in our body. Our senses, movement, our speech, our personality, memory, everything. Yeah.
In terms of, I think it's important because it's important that we explain, because it's easy to assume that everybody knows what we mean by the nervous system. And I think because as lay people, we'll refer to the nervous system when we're talking about like anxiety and trauma-related stuff, but maybe you can explain it to us, because I think it will help us understand how everything connects. You touched on like muscles and things like that, but how it all really does connect.
So the nervous system actually is divided into two. We divide it into the central nervous system, which is the brain, and then the spinal cord. So the information flows like that. And then there's this infinitesimally small gap, but then it begins the peripheral nervous system, which encompasses the nerve, which then goes to the muscle. So it's two parts, the peripheral nervous system, the central nervous system, and there's different disorders that affect both. So for example, if we're talking about MS, that's a disorder of, or a disorder of the central nervous system, which is the brain and the spinal cord, but there are other disorders of the peripheral nervous system.
I had never even heard of a peripheral nervous system because everybody speaks about central nervous system.
Yes.
So when you say nerves, can you give an example of how a person would experience something that you say that is a nerve? Not in the you're getting on my nerves.
Yes.
That's biologically.
So a nerve, there's different types of nerves, many different types, but broadly speaking, you can get motor nerves and sensory nerves. And the most common thing is like if you've slept on an arm or if you've been leaning on your arm and you start to get pins and needles down one of the fingers, you've been pinching the nerve or compressing the nerve and you get symptoms in that. Or if you've been sitting cross-legged and you stand up and the leg feels numb or you've got pins and needles, that's because you've been sitting on or pinching a nerve while you...
I got you. Okay. I think we've got a basic lay of the land of the human body and your area of expertise. So when we look at multiple sclerosis, I know that quite often in the medical field that the terminology is almost literal. So what does sclerosis mean? And then let's join the multiple part and then delve into do they refer to it as a disease, an illness, a disorder?
Multiple things, but I mean, the name is actually quite an old name, and sclerosis literally means scarring. So multiple sclerosis is multiple areas of scarring in different parts of the central nervous system, which is in the brain and the spinal cord.
So when we say scarring, obviously you get hurt, it develops a scar. Why is scarring bad on one's central nervous system?
So if I can maybe describe the nervous system and what MS does, so if I can use an analogy. So if we think of the nervous system like the wiring of a house.
Yes.
So...
Sorry, electrical wiring.
Yes. Sorry, electrical wiring of a house.
Because I know somebody was thinking Wi-Fi.
Yes, not Wi-Fi.
Yes.
The electrical wiring of a house. And just like the nervous system is controlling, as I said, sensations, our thoughts, our speech, swallowing, our balance, movement, everything we experience. It does that by these electrical messages that are going, like the electricity conducts through the electrical wiring of a house. And like the electrical wires of the house that have insulation, so electrical wires, I don't know if you remember science from school, but the insulation helps the electricity to conduct a little bit faster. Each nerve also has insulation. It's called the myelin sheath. And what happens is with multiple sclerosis is that the body's own immune system mistakenly attacks predominantly that insulation of the nerves. And it, to varying degrees, sometimes it just causes that conduction of the electrical impulses to go a little bit slower. Sometimes it causes it to be distorted, or sometimes it stops it completely, and it leaves these little, what we see on the MRI scan, these little white marks. And that's what the sclerosis, the scarring is referring to.
I got you. So in essence, if the insulator, so if we use the 3-pin plug, red earth and whatever, so if that outside part, that insulation is the one that goes, so it's like an exposed wire.
Yes, so the job of the insulation is to make the electricity conduct more effectively and to conduct faster. And as I said, predominantly the immune system in multiple sclerosis is mistakenly attacking that insulation. It can attack the nerve underneath or the wire, but mostly it's attacking that insulation on the outside. And so then, yes, there can be these little short circuits, or it doesn't conduct fast enough and the messages are not going where they should be and in the way they should be.
Yes. Okay, so when it comes to the research part and where we are with science today, are we speaking about a diagnosis that has no cure, but you can do things to delay, slow down, relieve symptoms?
So yes, well, I'd love to say that we have a cure, and we don't, but we don't yet. But the wonderful thing is that there has been so much research and so much progression over the last 2 decades. Within my time practicing as a neurologist, going from not much treatment available and not really understanding what's going on to now where we have so much more medication that's a lot more effective, and we can really get on top of. That's the goal, is to get on top of the disease, not chasing it from trying to treat attacks or anything like that. We want to get on top of it and diagnose really early. So there's so much research going on. Probably the most research is going into multiple sclerosis. That when we see the articles that get published, there's a lot, and it's really exciting and very hopeful. Yeah.
And South Africa, where do we sort of fare with regards to multiple sclerosis from the medical field? You know, do we have many neurologists that would be lauded as, if you have MS, this is the person? And in terms of South Africans, I mean, where are we statistically with the number of MS cases, even if it's just a very, very rough guesstimate?
Yeah. So one thing that's fantastic about South Africa is that we are practicing, or the medicines that we have available, when we see what's available, people might think in first world countries like the US or in Europe, we have everything available to us, which is fantastic. We don't have as many neurologists in South Africa as those countries do, which does lead to a problem with access and ease of access to neurologists. But we also don't have as much MS in South Africa for various reasons, but it is more prevalent in the US and in Europe. But I can't really give exact prevalence. Our data and our statistics are quite old, and they weren't taking into account a lot of factors. But we do know now that it is a lot more prevalent than we initially thought it would. There's been some myths in the past about perhaps certain races that particularly the Black South African race, they felt that did not get multiple sclerosis. And now we know that's completely not true. Multiple sclerosis can affect any gender, any age, any ethnic group, any race. It really does affect everyone.
In terms of the immune system, what is happening that the immune system, and maybe there might not be a layman's version of explaining, but as best as you can, what is the immune system seeing that is making it say, we're going to attack? What is so different about those individuals versus those that don't have MS?
So there actually are many different types of immune-mediated diseases in medicine that are more commonly known, perhaps more commonly known than multiple sclerosis. So, for example, type 1 diabetes or rheumatoid arthritis,
yes,
or systemic, so SLE. Those are also disorders where the body, or psoriasis, things like that, where the body's immune system is mistakenly identifying certain parts of the body, depending. So in diabetes, it's certain cells in the pancreas. In arthritis, it's certain cells in the joints, but or certain markers. Not certain cells, but certain markers. But so there's many targets. The immune system is an incredibly important thing, and its job is to fight against basically the enemy that's in the body, bacteria, things that shouldn't be there. But sometimes it can become a little bit mistaken, a bit hyperactive, and start identifying friendly markers as foe markers and attack those. So we know that there are certain markers on the myelin sheath. So this is the insulation sheath that certain cells will identify and attack. But we don't know fully exactly the cause and why it would happen in one person and not happen, or one sibling and not another sibling. So we know that there is a bit of a genetic susceptibility and there's some environmental triggers, but we still can't yet understand fully why one person, not the other.
What are some of the early symptoms that a person would start to experience? And this is long even before they get to you. I'm sure by the time they get to you, they might be telling you of a year's back and forth, here, there. But so that somebody watching maybe could recognize from the early stages when they go to the GP, what are those early symptoms that people usually come in complaining about?
So this is one of the tricky things with multiple sclerosis. Because this nervous system, so the brain and the spinal cord that does everything in the body, because the immune system can attack anywhere and to varying degrees, there is no classic, this is definitely MS, this is definitely multiple sclerosis. So many times a patient will have noticed, especially in the past, oh yes, there was this thing and I forgot to mention it. But things will come. So for example, even in the visual system, one patient will lose vision completely, another patient will just lose color vision, another patient will just have pain in the eye, and it's all the same disease, but presenting very differently.
Sure.
So that's why it can be quite tricky for a healthcare provider the first time a patient comes in complaining of something. It can be quite tricky to think of MS as the first time or as the first diagnostic consideration. So medicine usually considers the more common explanation or the more common diagnosis first, which is good medicine. That is what it should be. So if a 20-year-old comes in with pins and needles to the clinic, somebody will think it might just be a trapped nerve or a pinched nerve, or
and send you to a physio or whoever.
Or fatigue. There was fatigue, and it's stress, or blurred vision in the eye. There's so many more common causes of blurred vision in the eye that is more common than the inflammation that happens in MS. But there are certain things standardly that people should not ignore. If you lose vision in your eyes, don't ignore that. Seek medical help. If you've become numb on one side of the body.
So would that be like an overnight thing? Is that how it can attack? Like you wake up one day and you can't see, or like you've got significantly less vision?
Typically, so, I mean, if you lose vision suddenly, still you go to the doctor because it could be a strokes typically will occur because a blood vessel blocks that, because a clot blocks the blood vessel quickly. It's a sudden onset of loss of vision or paralysis or numbness, things like that. In multiple sclerosis, because it's inflammation and the inflammation of the nervous system, what happens is typically the symptoms develop over a couple of hours and days.
Wow.
And then typically last weeks, days, weeks, months. So the blurred vision that happens when you wake up in the morning and then goes away, that's not your typical, or the pins and needles because you've been leaning on something that goes away. The MS typically, as I say, evolves and then lasts longer than 24 hours. So if you have any overt neurological symptoms, if you've lost vision, don't wait to see, is this going to last more than 24 hours? If you've lost vision, go to the doctor. But the typical MS stuff that can be a little more subtle, like the pins and needles, it started in your pinky, and then by the end of the day, it's maybe, or the next day, it's involving the next finger. So it's progressing. The vision is blurred for longer than 24 hours. Those are the things that are more red flags. And also symptoms that you might have had very subtle blurred vision last year, and then this year you've got a bit of pins and needles. So symptoms that affect different parts of the nervous system. Those are also diagnostic clues for the healthcare providers.
What are some of the more rare symptoms that you see within the MS journey that maybe doesn't get spoken about a lot? Because, for example, everybody will understand the basics of diabetes, but they won't necessarily connect the dots to, eyesight and all the other stuff.
So we have what we would consider classic MS things. So, for example, the inflammation in the eye, we call that optic neuritis. That's loss of vision, even if it's partial loss of vision in the eye. Spinal cord syndrome, so that is where you've got weakness in the legs, difficulty controlling your bladder. These are usually things that are quite overt and concerning and would make people go to the doctor quite early. But there are some more subtle things that can be, you yourself might put it down to stress, vitamin deficiency, I didn't eat well. So things like fatigue, the MS fatigue, is not your typical, I'm just a bit tired, I didn't sleep so well, that kind of fatigue. The MS fatigue is, some patients have described it like they just feel like their plug has been unplugged from the wall, and just day-to-day normal activities are exhausting and overwhelming.
I actually thought you were going to say it's like if you've taken a sedative, and is that what the exhaustion feels like?
It's like there is no No, I suppose it could. It is very difficult even for patients who experience that fatigue. And these invisible symptoms are even if they have the diagnosis, for them to then go to work and be dealing with this fatigue, or family members or their spouses and their kids, and they're trying to say, you know, mommy can't really do this right now because of this severe fatigue. It can be quite frustrating because patients with MS look well. Many of them look very well, and you wouldn't think, oh, they're struggling with something, but they might have pain, they might have this fatigue, brain fog. So there are some symptoms that if you do go to your healthcare provider and say, I've got so much fatigue, they're going to check for the more common things, which is good medicine. It's not a mistake, but looking for the vitamin deficiencies. What is your sleep like? What medicines are you on? Is it stress? They're going to think about that first. And we call those the invisible symptoms.
Yes,
and those can be quite tricky. It's easy if somebody comes in, not nice for the patient, but if they're coming in paralyzed or blind in one eye, yes, everybody panics and the diagnosis. People make the diagnosis quickly. But if somebody's had a bit of blurred vision or a bit of balance problems, or maybe just a little bit of bladder issues, they're a little bit of an overactive bladder, they're going to wee more often than normal, that's not a red flag really for anyone. And so that those diagnoses can be delayed.
If you're sitting at home thinking, I also have brain fog, I also have this, I'm also doing that, I'm like, I check 3 on the list.
Yes.
But how then does it get it diagnosed? Because it must be so difficult to diagnose if, like you say, it could be, I'm a 41-year-old woman with perimenopause, and that's why I have brain fog, and I have a newborn that was a surprise baby, and that's why I'm tired. And, you know, so...
I've got pins and needles in my body. Yes, yeah.
Yes, yes.
Yes, so if you are worried, if you think, oh, I'm checking these symptoms.
Yes.
Number one, don't panic. There are many other causes that, like perimenopause, like vitamin deficiencies, but...
motherhood.
And motherhood. And lack of sleep.
And motherhood, being a parent.
So don't panic, but go to your doctor and just talk about the symptoms. Bring up the concern, could this be MS? So MS can be relatively easy to diagnose if it is considered. So once you've thought about it, the healthcare provider can say, either no, it's not MS because, for whatever reason, because the pins and needles happened when you were sitting cross-legged and it went away, so we're not worried about MS in this case. Or the healthcare provider can say, actually, yes, let's send you to a neurologist. And even if, and I would encourage people, if you've been given an explanation and you just think, I don't know, because I think it's just lasting longer than it should, or it's very reasonable to go and just say, look, what about a referral to a neurologist? Can I go and get an opinion about this? And then it's up to the neurologist then. You know, the neurologist's greatest diagnostic tool is listening to the story. Most of our diagnostic ideas or our differential diagnosis, so that's this list of what could your symptoms be. We spend 80% of the time listening to what the patient is saying and getting this history of, you know, what's happening now, how long has it lasted, how did it start, what happened last year, has something ever strange happened in the past, even if it was 5 years ago. So we listen to all of that. And then once we do a targeted examination and saying, okay, so we're hunting, we're not fishing, we're now hunting, and then we do tests, and we do an MRI, sometimes a lumbar puncture, not always, and then we have the diagnosis.
So let's talk us through, if I'm a patient and I come and I say, look, I just wanted to be safe, and I've been referred. What are the questions that you start asking? I say, I watched Relebogile's podcast. I saw them speak about multiple sclerosis. So I asked, so here I am. So you already know when I walk in the door, or let's assume actually that MS was not even a consideration, but I've been sent to you. What are the lines of question that you usually start with?
So I would encourage any patient, if they are seeing a specialist with neurological symptoms, to write down in a diary, wherever, what the symptoms or some of your concerns. Because when you get into the neurologist's office, it can be nerve-wracking, and you forget, and you walk out that door at the end of it and you think, oh, I forgot there was this thing. So if you do come in, the more information you can come in with, that's the more information we have to put together. So it's like we're detectives. You'll start off with saying, oh yes, there might have been, or you worried about one. My doctor sent me here because I had blurred vision in my eye for a couple of days, 2 weeks ago, but it's gone now. So I think it's fine, but my GP is just worried. And so then I would ask about how it started, were there other associated symptoms, what was going on in your life? So were you having on other medications? Were you sick? Did you have fevers? Things like that. And then go into your history. Had you ever had any issues with balance before, where you thought maybe I've got an inner ear, I've had an inner ear infection, so my balance hasn't been good? Have you had episodes like that? Or have you had episodes where you couldn't control your bladder, or pins and needles in the arm that did last? So these symptoms we're looking for that lasted longer than 24 hours. So we're not really concerned with the symptoms that are lasting minutes. The pins, those are the normal. We all wake up with a stiff neck in the morning, or the arm, and it's not working because you slept funny on it, or pins and needles in the hand at night because you've bent your arm funny. So we delve into what you're currently experiencing, and then we try and tease out anything in your past that could be symptoms related to the nervous system, so the central nervous system, when we are considering MS.
Do you confirm with MRI? So if now the symptoms are ticking certain boxes in the story, is the next step bloods, or are we going straight to an MRI machine?
Depending on what the symptoms are, because you always do want to make sure that the vitamin deficiencies, if there's other things that are going, if you are tired, if you're looking pale, I will check your iron levels.
Yes.
And so we don't often just jump straight, but sometimes there are these signs, and on examination and on history, there's been red flag signs. So we do blood tests, but there isn't a blood test to diagnose MS, unfortunately. We do some blood tests to exclude other causes.
For elimination.
For elimination.
Because we always wonder, why am I doing blood tests again? Now we know.
Yeah,
okay.
we want to exclude the more common, like what's your thyroid like? Because thyroid can make you really tired, can make you have brain fog, can give you pins and needles if your thyroid is out. So we check the common things, but the diagnosis then is that cluster of symptoms that you've got on history. We make sure that there's nothing mimicking it on the blood test, nothing overtly out, but the MRI, there are some classic patterns on the MRI. The MRI scan is the one that solidifies the diagnosis for us.
What are the common similar diagnoses that MS could look like?
So it depends on what your symptoms are. So once again, like if you're having difficulty controlling your bladder, it might be just something as simple as a UTI. So you could have a urinary tract infection. So it's just something very similar. Or perimenopause and menopause, where your bladder is just not functioning as well as it is. Or if you've got pins and needles in your hands and feet, might be vitamin B12 deficiency. Or with fatigue, brain fog, could be thyroid, or diabetes also could cause pins and needles. So there are some mimickers, but it doesn't mean if you have diabetes or thyroid problems that you don't have MS. So that MRI, so even if you do have something on your bloods, the MRI is diagnostic. It looks a certain way in MS.
In terms of the symptoms that come and go, why does it do that? Why, if it starts with the blurry vision, does the blurry vision go?
So it doesn't always go. So if you are lucky, it does get better. So what happens is the immune system is attacking that insulation, so the myelin sheath, and it just depends how aggressive that inflammation was. So sometimes it can just erode through a few layers, sometimes it erodes through all of the layers, and sometimes it goes all the way through and can damage the nerve underneath. So if it damages the nerve underneath, the recovery doesn't always come back fully. But most of the time, it's just in that insulation layer. And so the inflammation almost burns itself out after a while. And then the body starts to remyelinate. The beautiful thing about the body and the insulation is that it can start regenerating the insulation. It does a lot better at regenerating the insulation and repairing the insulation than it does the nerve itself. So when when somebody does have an attack of MS, which we would call a relapse, we often give medication to try and shorten that, so to shorten the amount of time that the inflammation is there, so that it doesn't give it enough time to erode through as many layers of the insulation. And then, so it's got this inflammation and it's this attack, and then it plateaus when the inflammation stops, and then you've got to wait for it to recover.
Ah, got you.
And then that's when some symptoms start getting better and the vision can start getting better. And that can take weeks, months even.
Does the MRI tell you how bad the erosion might be, or does it just confirm it's MS and then you only sort of assess based on the symptoms?
It can't tell us how bad the erosion is. It tells us there's certain sequences on the MRI if there's active inflammation. But what it can do, there's certain patterns that make us think, so this looks like it might be a little bit more of an aggressive type of MS, because MS can attack, there's areas of the brain that we don't realize that we're not using. So if it attacks in the sensory cortex, you'll feel pins and needles, or on the optic nerve, you'll lose vision. But if it's in a couple of other areas, you might not even know that there's little scars there. And so if you might just come with loss of vision or blurred vision in an eye, but we do an MRI scan. One patient might just have inflammation on that optic nerve, and another patient might have inflammation on the nerve, but then a whole lot of spots all over the place. And then we also have a look at the spinal cord. And there's some patterns that make us think, sure, we're a little bit worried that this might be a little bit more of an aggressive form of multiple sclerosis, so we'd rather treat that one with a little more aggressively than another one. So we're very fortunate. We've got a lot of options in terms of what we're going to choose to treat to try and control the inflammation and the disease activity. So we can start with normal first line, what we would consider first line. It's a little bit outdated to think that way, but we have more aggressive ones. If we're looking and we think, look, this looks like it's a little more aggressive, let's start with more aggressive treatment.
What are the treatment options or plans that are given to patients? And maybe you can speak to minimal symptoms, early onset, we got it right at the beginning, versus a person who is in a fully aggressive MS, but also quite far down the line in the degeneration of, or progression rather, of the disease.
So I alluded to it a little bit earlier, but the beautiful thing is that the treatment of MS has changed in the last 20 years within my practice life. And so we've gone from chasing attacks, so if you have an attack, let's treat the attack, to now putting patients on medications to prevent these attacks and prevent the loss of the insulation and prevent the loss of the nerves. So, but the earlier we diagnose MS and the earlier we can start treatment, the earlier we can prevent this progression. So there is no one that we say, you have MS, it doesn't look that severe, it looks like it's a mild form, so let's just wait and see. There is no one that we do that to. Everybody, if you've got MS, we put you on treatment, because we know that unfortunately we don't have a cure yet. And we also know in the last decade, research has shown that the activity of MS is not just related to these attacks, so these flare-ups where there's obvious new neurological symptoms. The research has shown that in the background there is, or often is, low-grade inflammation. So that is why we say, even though you might feel very well and you don't think you are having any symptoms, we need to have you on some form of treatment to just calm the immune system down so that it's not working in the background and you're not just waiting for a flare-up. So 20 years ago, we had only injectable medications available.
Is that like cortisones?
No, so cortisones are still a mainstay, and we treat acute these attacks, so a flare-up. So when the immune system is particularly active in one moment and you might then have an attack or what we call a relapse, we still use cortisone. But they were the medications that if you can think of like those EpiPens, yeah.
Yes.
So things like that.
Which is
an
the
equivalent.
adrenaline injection for anaphylaxis,
Yes.
allergies, blah, blah, blah.
Yes, so it's something like that. So, but it was still not nice for patients. So some of them were quite shallow, some of them you had to give into the muscle. So those patients, it wasn't nice to have to inject those, but they did work. And some patients are still doing really well on them. But it's become a lot more diverse. There's now been oral tablets. There's now infusions that you only have to give once every 6 months. There's injections. We've just got so much available to us. So the important thing is that we try and ensure that this treatment doesn't interfere with your life. Because MS typically, although it can affect any age group and start at any age, the most common diagnostic age group is in people's busiest time of their lives. So when you're starting your business, you're building your business, you're building families and all of that. So we want, the aim of treatment is to help you, so to prevent disease activity and help you lead just your full active life with minimal side effects. Yeah.
When we look at the progression, so let's say a person is on treatment, but at some point it becomes drug resistant, if that's even a thing with MS. But what does the severe, we're quite far down the line, look like? What does that quality of life, day-to-day life look like if we're talking, we're very far down the line and whatever treatment is being used, it can't take the person backwards. It can only maybe slow down what's happening going forward.
So one of the common questions, and I think this might be where you're going, is are we going to land up in a wheelchair? I think that's one of the biggest fears in MS. And that's a valid concern because in the past, when we didn't have effective treatments, that was what was happening. So if you do see patients that are wheelchair bound, generally, for the most part, those are patients that have had MS for a very long time and haven't unfortunately benefited from the new research and the new medications that have become available. Most patients with MS never land up in a wheelchair. Okay. They're leading fantastic lives. Our plan is we have you on medication, and if you have a relapse, so a relapse is where there is this flare-up of activity of the immune system and you either get new neurological symptoms or worsening of some existing neurological symptoms. And if you don't have, and there's not a better explanation for it, so it's not like you have a fever or you're sick or anything like that. So if you have a relapse, if you're already on the treatment and you have a relapse, we then escalate to the next effective. So we have this tier that we escalate up. And the aim is to keep patients functional, working, having children, running their families. So most patients don't end up in wheelchairs. We have these medications. Really, there's been fantastic progress, scientific progress in the treatment of MS. Yeah.
Does MS have stages like cancer, for example, where, you touched on tiers for, I guess, protocol of treatments, but does it have stages where it guides within the medical fraternity how far along, where it's like, okay, if we're this is this stage, or doesn't work like that at all? It's a very personalized treatment plan for the patient.
We have something called the EDSS score. It's a expanded disability scale score. It's really not great. It's been around for a long time, and the funders still use it, and it's still talked about very widely in research and things like that. And it doesn't dictate treatment, but it just dictates disability. It's quite a complicated score. It divides the nervous system into big sections, like your visual section, your motor section, your sensory section, your cognitive section, and within each one of those, there's little subcategories of how you're doing and what disability you are, and then you add them all together and you have this overall score. And It's mostly got to do with how independent you are, but it's not a great score because it doesn't really quantify the invisible symptoms that we might talk about, like brain fog, things like that. So a patient might not have moved on their EDSS score, so they're still walking. EDS scores is quite heavily geared towards what is your mobility like and how far can you walk? Do you need a walking stick yet? Are you wheelchair bound? As I said, it's been around for a very long time.
But at least helps you gauge where they are. So like what you're saying, I'm assuming if it's the mobility part of either you can walk unassisted fine for hours and then it breaks it down to can't walk this distance without help.
And that was very helpful, especially in the past where we didn't really have aggressive treatment and the goal was now to try and keep you walking. Whereas now where we have, because we didn't have the luxury of, if you've got pins and needles or your balance is not that great, we didn't have the luxury of having other options to escalate your treatment to.
I got you.
So they would try and conserve and keep you where you are and only change you when they had to. Whereas now, because we've got so many options, we although your EDSS might not change because you're still walking fine and you still, but if you have terrible fatigue, we care about that. And cognitive dysfunction, or so your score might not change, but physically you're not the same person. We can, there are things that we can implement. Yeah, especially if we do MRIs, we have a look, because once again, there are many other causes of fatigue and brain fog. Just because you have MS doesn't mean that everything now is because of MS. You can still have everything else, like perimenopause, like stress.
Because you still have hormones, yes, you still have gynae issues.
Yes, yes.
Okay. Are there any systems in the body that get impacted by MS? So let's say gynecological. Can you still have kids? Can you still breastfeed depending what medication you're on?
Yes.
How much does it impact? I mean, you've spoken a lot about the goal is to ensure that your life is as disrupted as little as possible.
Yes. You can most definitely have kids. Yes. It doesn't affect your fertility. The one thing though is some of the medications can cause problems if you want to fall pregnant. So the plan is to chat with your neurologist. You can definitely fall pregnant, but you need to plan it. So no oopsies. And your neurologist will have, or should, they do. We have this discussion with patients to say, look, it's really important because some of these medications can be dangerous to the baby if you want to fall pregnant. So if you want to fall pregnant, come and speak to me. We have options.
I got you.
And then what we do is we would change patients over, but we need to know beforehand. It's best to know beforehand. But so by all means, yes, you can have kids. You can have as many kids as you want.
Speaking of kids, is it hereditary? I mean, I know you touched on it, but is it a thing that if a patient who has MS has a child, that you would keep a lookout with your neurologist regularly to see there aren't any markers, or you wait for symptoms?
So the short answer is no. It's not an inherited disease. There is a genetic susceptibility. Which means there's not a gene that causes you to have MS, but the cause of MS is multifactorial. So there needs to be, as we understand, there's a genetic susceptibility, but then there's environmental and other triggers that then affect it. But you can't, it's not inherited like some of the other neurological diseases, like Huntington's disease, for example, that you can pass down to your kids. So if you have an aunt or something, that does not necessarily mean that you're going to get MS. You don't pass it through to your kids. You can't pass it to a friend through contact or to your partner through sexual intercourse. It really is it's yours. Yeah.
In your line of work, I mean, you've spoken about you'd have a conversation with a patient about, do you want to have kids? What are some of the other things that patients come to you about? Like you mentioned sexual intercourse. So for a man, would he need to be worried that things still function as per normal? If he has MS, what are those other things that maybe get impacted that we are not aware of?
So it potentially can, but those are things that we then address. But like with any disease, not just MS, with diabetes, with blood pressure, because sometimes it can be side effects of medications they're on. So like any normal patient, if your patient with MS comes and says that they have a symptom that they're concerned about, doesn't necessarily mean it's MS related. Treat them like any other patient, take a full history, decide, look at the medications they're on, other diseases. If it is MS related, there are treatments that we have. We still refer to a urologist for help. There's medications that can be taken. So it really is focusing on normal life.
Urologist is the gynae for men.
The other brain, yes.
Sorry, that is so... The other brain.
There's been many times I've had patients come to me and start talking, and I'm like, do you think I'm the urologist?
No, this brain.
I'm the neurologist.
I get you.
Brain,
I get you. What are the things that maybe patients worry most about? I mean, I'm sure they ask you, am I going to die? When am I going to die? Share with us, especially because I think if somebody knows somebody with MS in their life, and like you said, they only deal with what they see, but they're not seeing the psychological impact. They're not seeing all of those other things.
I think the biggest concerns my patients have are the wheelchair. Am I going to land up in a wheelchair? Am I going to die? And am I going to pass this on to my kids? So that's, and because MS really is different for everyone, patients, it can be, as you can imagine, it feels like you're a ticking time bomb. You've just had this diagnosis and you now sit and you wait and you think, when is my next one coming? Is it going to come? Is it... And it's important for family members, for loved ones, and this is why I say to patients, bring either your best friend or your family members in to the consultation, because there's a lot goes on, and let them understand and have a bit of empathy, and we can discuss these things. But so we gear towards trying to address specific concerns, because I might think I know what your concern is, and I might say that. And I could be completely wrong. So here I am going on talking about, don't worry, most patients are not in wheelchairs, and don't worry, you can have kids. And that's not what you're worried about. You're worried about death, or dying younger. Unfortunately, we can't take away the anxiety of the ticking time bomb. And I say that to my patients. I think it's important to acknowledge it, that there is this anxiety. And then the next time you do sleep on your arm and you get pins and needles, you think, is this an MS relapse?
I get you, yes.
Or the next time you feel a bit dizzy when you stand up from your chair, you think, is this an MS relapse? And to have grace, it's important to have grace for patients, especially at the beginning of the diagnosis. Contact me. If you think there's a problem, come into the hospital. But with time, with the medication, eventually, and that's one of the joys of being able to treat the patients. Just this week, I had a patient come for her yearly follow-up scan, and she says to me, and I said, your scan is stable, good news, the medicine is still working, and this medicine, she's been on one of the first-line medications since 2020, so it's been 6 years, and she's like, just show me my scan. Are you sure I have MS?
Oh, man.
Because I'm well. Yes. She does yoga. She runs a business. She's like, please just show me. Are you sure? Show me what these things look like on the scan, because are you sure I've got MS? Yes. And that's wonderful. And those are the stories that I want to say to patients with the initial diagnosis. I know it might seem scary, but there are thousands of patients in South Africa like you, and join
the support group.
Join a support group. And if you are worried, contact. Let's just make sure, don't worry. But eventually you will see that the medications that we have, that you will be reassured that you can live a normal life. You can do your exercises. I mean, I've got patients that are physiotherapists, that are radiographers, that are doing Ironman, that are running businesses, mothers. You wouldn't know. You wouldn't know. And that's often frustrating for patients, because people forget that they might be struggling with the fatigue. So it can be frustrating for patients with multiple sclerosis. But it really is, there's hope, not to lose hope, because we've got good treatment. Early diagnosis, don't ignore your symptoms. Don't be scared about it. Chances are, most likely, the symptoms are probably not MS, but don't ignore them, because if it is MS, The earlier we make the diagnosis, the earlier we can start treatment, the more we can protect the brain.
Oof, I think your job is phenomenal. I have a lot more respect now, especially with what you've shared, because it is not just a straightforward, let's just do pee on the stick, okay, let's do the blood, therefore.
You'd make billions if you could, yeah.
If
Somebody
work on it.
Somebody work on it, yes.
Can we talk about, you've already spoken about the fact that neurologists are not as many in South Africa to begin with. Can we talk about access for people that are in public, healthcare systems? If people are waiting 3 months to see a gynae, how long in a public sector would they even get to see a neurologist?
So that is unfortunately a problem across, not just, as you mentioned, gynaes, not just neurology. There aren't many neurologists, and unfortunately the neurologists do tend to cluster towards bigger cities because we do need access to MRIs. MRI scanner, which is a big, expensive scanner, is part of one of the important investigations we need for many of the neurological diseases. So that's why neurologists tend to cluster towards the big cities. So patients who are in the more rural areas or in the outskirts often don't have as easy access to neurologists. So it doesn't have to be a neurologist that makes the diagnosis. If you are sitting with symptoms, go to your clinic, chat to the clinic, ask them for a referral. It will be a wait, but don't ignore it, because you need to advocate for yourself. As I say, we have the medications. Advocate for yourself. Say, I am concerned about this. Please refer me. If it takes you a couple of months, so be it. It will be worth it in the end.
Oh, Doctor, thank you so much just for sharing and making it so much simpler to understand. Your analogy is brilliant. I know you've practiced it enough on patients for it to be safe enough for us, especially just in terms of the awareness, not just for if any of us need to go and check if we have MS, but also just to be aware that there are people walking around in society that might look okay, but are absolutely struggling. And as, of course, Doctor has said, is that go and check, advocate for yourself. Don't be afraid for a second opinion. If you're a parent and you're not sure, go and check, especially if you see neurological symptoms. Doctor, thank you again for your time, and thank you to all of you for tuning in to the Relebogile Mabotja podcast. Thank you to Novartis for bringing us this conversation on MS. Please ensure that if you notice any neurological symptoms and you are doubtful, you are unsure, please go and seek medical attention. This right here is for educational purposes, and we hope it raises the necessary awareness, not just on MS for those of you that could be patients that don't have a diagnosis, but also for all of us, because we live together and we get to find out more about what can be a very debilitating disease. And we are so happy and grateful to hear that medication has advanced, and hopefully one day there will be a cure. Thank you so much for joining us. Comment down below your questions. We'll also make sure that we put some information in with a link down below for you to check out about MS, and we'll see you next time.